A continuación voy a presentaros al siguiente ponente. Tenemos con nosotros a Jeffrey Lazarus, que la verdad es que resumir el currículum es bastante complicado. Él es el jefe del grupo de investigación de sistemas de salud en el Instituto, en el IC Global en Barcelona, es profesor de la Universidad de Barcelona, investigador senior en la Escuela de Doctorado de Salud Pública y de Políticas de la Salud en CUNY, en Nueva York, y ha trabajado durante muchísimo tiempo en la OMS como experto en sistemas de salud, en VIH, en hepatitis virales. Después también ha trabajado en el Fondo Mundial de lucha contra el SIDA, contra la malaria, contra la tuberculosis. La verdad es que ha tocado muchísimos aspectos y ha participado en muchísimas agencias siempre relacionadas con sistemas de salud. Quiero destacar que es investigador en múltiples consensos globales, estudios de política global, de salud pública, y actualmente es copresidente de la coalición HIV Outcomes más allá de la supresión viral. Y desde luego es líder indiscutible de lo que se ha llamado la propuesta del cuarto 90 sobre calidad de vida relacionada con la salud en las personas que viven con VIH. Él, tenemos la fortuna de que nos acompaña, tiene la charla en español, la tiene en inglés, la va a dar en inglés, y el título es The Role of the Health Systems in Advising the Long-Term Well-Being in People Living with HIV. Cuando quieras, Jeffrey, gracias.
Thank you very much for the kind introduction, Chair. I would add that although I was at the Global Fund to fight AIDS, tuberculosis, and malaria, I was only focused on AIDS there. That was enough to keep me busy. Thank you very much, Hesida and Cecida, for the invitation to speak in this session. I'm very sorry that Dr. Maria Jose Fuster couldn't join us today. It's an unpleasant reminder that the COVID-19 pandemic is clearly not over, even if many of us would like it to be. So I am going to focus on health systems and how to take a people-centered health systems approach to ensuring quality of life for all people living with HIV. And really picking up where Megan stopped, I mean, we may lack a global comprehensive COVID-19 strategy, but we were fortunate this year to have passed at the World Health Assembly in May a global health sector strategy on HIV. And it's interesting that it's a global health sector strategy, recognizing that HIV cannot be addressed solely in the infectious disease clinics. Also, it's a strategy, a WHO strategy, that for the first time combines HIV, viral hepatitis, and sexually transmitted infections into one strategy. And instead of being a 5-year strategy, it's a strategy that extends to 2030 in line with the Sustainable Development Goals. Now, the WHO strategy calls for a more precise focus to reach the most affected and at risk of HIV and AIDS, to address inequities as they prevent the world from ending the AIDS pandemic. And it's an opportunity to go beyond antiretroviral therapy and viral suppression, taking a more holistic, people-centered HIV care approach focused on long-term well-being, addressing health-related quality of life, multimorbidity in people living with HIV, including non-communicable diseases and mental health conditions, as well as the persistent problems of stigma and discrimination. It's a long strategy. I would draw your attention to this figure. It's a figure we're familiar with from the 390s. And although many of us have advocated for a fourth 90 addressing long-term well-being and quality of life and health-related quality of life, earlier that wasn't a part of the WHO strategy. Now, if you read the fine print and you look at the third bullet here on the bottom, you'll see, as Megan also mentioned, that now WHO does call for addressing additional outcomes for all people living with HIV, including achieving good health-related quality of life. What they don't do in this strategy is make a commitment to monitoring global progress toward improving HRQOL outcomes in people living with HIV and assessing impact and service coverage. So Megan and I and many others in the HIV Outcomes Coalition and around the world believe it's incredibly important to measure it in order to establish a baseline to see where we're lacking issues. And in this talk, I'm going to be discussing some of the top-down approaches, policy issues like these developments at WHO, but also a bottom-up approach. What can we do at our clinics and our hospitals or in a single country to get and maintain HRQOL on the forefront of the HIV and AIDS agenda? So addressing HRQOL related to people living with HIV can be relatively new for health systems, at least when we go beyond the issues of viral suppression. And without institutionalized targets, health systems may not recognize the importance of reporting on the HRQOL of people living with HIV. Now, WHO made specific mention of inequalities and inequities, terms that are often used interchangeably, and indeed so in the UNAIDS strategy at times. But I think this image really makes it clear. When we're talking about equality, we're talking about something very different than equity. And I think you see here, if we say that a picture is worth 1,000 words, we know that when addressing HIV and AIDS, we need to address the equity issue. Those who have particular challenges in accessing health services, in continuing in care, in adhering to the effective antiretroviral therapy that here in Spain they're universally offered. So inequities and inequalities. Last year, UNAIDS said inequalities are a key reason why the 2020 global targets were missed. The inequalities that underpin stigma, discrimination, and HIV-related criminalization, enhance people's vulnerability to acquire HIV, and make people living with HIV more likely to die of AIDS-related illnesses. Hence, strategic priorities need to be centered on a comprehensive, people-centered HIV service. I'm going to explain what I mean by that and how you might address it at your services, at your clinics, at your departments. It means centering on the removal of societal and legal impediments to an effective HIV response. And in 2018, Spain really removed some of that discrimination that was still on the books about what kinds of jobs, for example, people living with HIV could get. And we need robust and resilient systems to meet the needs of people. That sounds very cliche, but we've learned during the COVID-19 pandemic that the great health systems, including here in Spain, were not as resilient as we thought them to be. So what are the 2025 HIV targets? Well, there's lots of targets related to less than 10% and more than 95%, focusing on reducing inequalities. I won't go through them in detail, but we know that the health systems need to be monitoring them, both nationally and at the autonomous community level. For example, less than 10% of people living with HIV in key populations experience stigma and discrimination. At least in terms of discrimination, that should be 0 here in Spain. Greater than 95% of people at risk of HIV use combination prevention. We have the tools here in Spain. Those numbers can be even higher. And so on and so forth. There's a lot of targets, but it's important to measure them, to analyze them, ultimately to improve the health-related quality of life of people living with HIV, improve their adherence, and as Megan mentioned in the WHO definition, it's not merely the absence of disease or infirmity, but also a complete state of physical, mental, and social well-being. And that means combating stigma and discrimination. Stigma and discrimination are often mentioned in one breath. It's important to separate them out. Discrimination is often on the books. There's legal discrimination. There are rules and regulations that we can identify that are discriminatory and need to be removed. There's many different kinds of stigma. It's well studied. There's structural stigma and societal stigma. These can contribute, and stigma at the healthcare system level. All of those forms of stigma contribute to self-stigma, which can result in not going to services, not adhering to medications, and poorer health outcomes. So what can we do? Well, For those of us working in the healthcare system, we need to make sure there's no stigma and discrimination in any healthcare setting. We need differentiated service delivery and legal, regulatory, and policy reform in some settings. We need to address gender issues, not just sex issues, but the full gamut of how we understand gender. We need to understand that the use of digital health technologies, while a great leap forward, can also lead to a digital divide, where those populations worse off with lower socioeconomic status do not benefit from the digital health services like video consultations or confidential healthcare consultations, because they don't have the internet bandwidth to do this. They don't have the privacy to be able to have that conversation. They may not even have a smartphone to make that call or a place to go to do it. We need to make sure that we have multi-sectoral partnerships. We're not going to end this alone from the healthcare services. And we need to make sure that the workforce is fit for purpose and understands all of these issues, and that it's not just about taking your pills or injections. And all of that leads to the importance of tracking progress with indicators. So by 2030, for example, less than 10%, as I mentioned, of people living with HIV should be reporting having experienced stigma or discrimination. There's a critical role of the health sector in enabling and leading a multi-sectoral health in all policies approach required to remove structural and systemic barriers to accelerating the process of ending the HIV epidemic. We need to make sure we have disaggregated analysis of data by sex and gender and age and other relevant population characteristics, and that we also report and analyze this data. It can be very complicated to go through some of those reports, so we need to make sure that there are simple take-home lay summaries of the data that's being collected. And we need to continue pushing for universal health coverage, something we have here in Spain, but I understand there are issues in some cities in Spain with people living with HIV who are not legal migrants, who are not citizens or permanent residents here, in accessing their medications. That should not be the case anywhere in the world, and it certainly shouldn't be the case in Madrid. We're at a time when we're making a paradigm shift into a new era for HIV care. So while it's true that in the UK, already 12 years ago, they started talking about beyond viral suppression, most of the world has been behind in that conversation. The conversation focused on moving from disease-centered HIV care that was focused on antiretroviral therapy and viral suppression and reaching the 390s and now the 395s, to one that's focused on people-centered HIV care with its focus on long-term well-being and health-related quality of life to achieve long-term success. We made a great advance ahead of the UNAIDS strategy back in 2016 when we called for beyond viral suppression of HIV as the new quality of life frontier. And we called for what we coined back then a fourth 90 that was well taken up. It became a fourth 95, and now, as mentioned, is integrated into the WHO strategy in their call for monitoring health-related quality of life and long-term well-being for all people living with HIV. I think it's interesting to look at the WHO health systems framework back from 2007. On the left, the different building blocks, the different parts of a health system, how they need to interact in order to improve access and coverage and ultimately improved health, the goal of any health system. And you see here in parentheses, kind of hard to read, level and equity. And that means that when we're looking at, for example, greater than 95%, we have to break it down by subpopulations, by key populations. Are greater than 95% of people who inject drugs, or female sex workers, or undocumented migrants also meeting those targets? It's not enough to achieve it at a national level or at an autonomous community level. We need to engage more with patients, more with the community. So we rejigged a few years ago the health systems framework and added that in, as well as the importance of communication, because not all parts of the health system speak well together. WHO took this on board and launched what they called the people-centered health systems approach, putting people at the center and showing the dynamic interaction between the different parts of a health system. What we can do to make that fit for purpose for us is ask a number of questions. If we have a national strategy or a plan at the autonomous community level, was it developed with the involvement of people living with HIV and key populations? Do we have the workforce needed to address the issue? And that means community services. Are we going into the community to meet people where they need to be met, to get tested, linked to care, and even get their medications provided? Do we have the budget provision for this kind of action? Do we have the capacity to monitor, and are we using all of that capacity to monitor in every autonomous community and at the national level so we can aggregate data and understand how well Spain is doing vis-a-vis other countries? Do we have strategies for engaging all affected populations, all key populations? We have for some. Do we have those strategies and action plans in place for every population? And do we have an easy to collect and understand health information system? Well, I speak Spanish and a few other languages. It's not always so easy to understand what's being reported in those documents. So again, we need them broken down and explained in lay terminology so we can know where there are gaps and what we need to do to address them. So I mentioned the importance of marginalized groups who are at a higher risk of vulnerability. Some of them are listed here, and we know that when we have those kinds of health risks, it leads to healthcare access barriers, lower service uptake, and poorer outcomes. To address this issue, across Europe, we formed a coalition called the Nobody Left Outside Coalition, focusing on improving healthcare for marginalized and underserved people. It includes professional medical societies, but also organizations representing the different key populations, from the European AIDS Treatment Group to FEANSA, which addresses homelessness across Europe, to PICUM, to the Africa Advocacy Foundation, and others. And we developed a health systems checklist. So a checklist that you can use to apply to your own service, to your own clinic, to see if it's working for the populations it's meant to serve. Let me zoom in on that. You can see it follows the framework of the WHO health systems building blocks and asks questions like at the design stage. Were community representatives involved in the design of the service? Are the health and social care needs of the community being addressed, or as is often the case, only the health services? And we saw great data that Megan presented from the UK, where people living with HIV had most of them reported having their HIV needs taken care of, but not all of their health needs and not all of their social welfare needs. So again, I won't go through all of this. It's a very long checklist. You can use a shorter version. You can translate it. But what you can do is apply it to your own clinic, either alone or with colleagues or with the communities and with your patients, to see if your services are working well for them and where you might need to improve them. We're at a time when we're talking about integration and convergences. And integration doesn't mean everything in one place. It doesn't necessarily mean co-location. But it does mean good referral services. And by good referral services, it doesn't mean, like you see here on the image to the left, that you report the opening times of a particular department where you referred your patient to, and have an arrow even in which direction to go at your hospital, some of which are quite large or spread over several buildings to go in. It means that one person, one clinician or nurse, one healthcare provider explains to the patient what care they need, what appointments they have, how many times, hopefully not many, they might need to go back to the hospital or clinic to receive those services. We need to remember that there are real out-of-pocket costs. There are opportunity costs. There are many challenges to going to many appointments. We need to put ourselves in the shoes of a patient and think about how challenging it can be to get to the hospital. When they arrive, they may get high-quality care, but unfortunately, many do not arrive. And that's the challenge we're facing. With all of this discussion around health-related quality of life and the creation of a new, or the development of a new WHO strategy, a group of us from around the world developed a consensus statement on advancing the long-term well-being of people living with HIV. And although there were many statements and high levels of agreement, a little lower on some of the issues related to stigma and discrimination, maybe reflecting the makeup of the panel, because patients, people living with HIV, had a very different view on stigma than some of the healthcare providers. But we came up with 5 key next steps for health systems to advance the long-term well-being of people living with HIV. Firstly was the monitoring of comorbidities. And you might say, well, we do that. We follow the guidelines. We're monitoring comorbidities. They need to be in electronic health records. They need to be aggregated at the autonomous community level and at the national level. We know we have a lot of data. We understand what's happening in the country thanks to the good cohorts across Spain, but we need the national services also to be reporting at least some of the key comorbidities, so again, we can tailor our interventions to address them. We need frameworks for healthy aging and frailty and functional ability, issues we can now address because the majority of people living with HIV in Spain and around the world are diagnosed, are linked to care, and are suppressing the virus. We need to reduce access barriers for marginalized and vulnerable groups. During the COVID-19 pandemics, colleagues of mine in Madrid went out in their mobile units. They tested for 100 people for HIV, for viral hepatitis, after giving them a COVID-19 vaccine that they had not received, although more than 90% of people in the autonomous community of Madrid had been vaccinated. They found 9% RNA positive for hepatitis C, and they found 4 cases of HIV. 4 people not on treatment, 2 were aware of their diagnosis, 2 were not. A small sample, but we need to address the marginalized and vulnerable populations. We need to collect and document data, as Megan clearly pointed out, on health-related quality of life, on experiences of stigma and discrimination, including in healthcare settings. And then we need to decrease that stigma and completely eliminate discrimination across society, but especially in our healthcare services. So some of the policy recommendations we have are to focus on stigma and discrimination, to tackle HIV inequities at their root cause, promote the transition of health systems into integrated, well-functioning health services, to integrate PROMs and PREMs into clinical practice, and to develop a monitoring and evaluation framework for HIV care that includes tracking progress of health-related quality of life of people living with HIV. So in conclusion, it's November 2022. We have an increasing aging population living with HIV, and we have to recognize the importance of addressing non-communicable diseases, including mental health conditions, social well-being, and stigma and discrimination. We have a need for a people-centered HIV care approach and a stronger integration of communicable and non-communicable diseases to achieve long-term success for all people living with HIV. We need these kinds of integrated service delivery models that include digital health, but without leaving anyone behind, and healthcare services focused on long-term well-being and quality of life. And a final objective, addressing HRQOL issues, the comorbidities, the stigma and discrimination, the inequities. And again, I draw your attention to WHO's revised HIV continuum of care. Still, starting with diagnosis, linkage to care and treatment, viral suppression, but additional key outcomes, making sure there's rapid treatment after diagnosis, engagement of in differentiated and chronic care, and importantly, for the first time in their strategy, achieving good health-related quality of life. I'd like to acknowledge everyone on my team at IS Global, some of whom are here in the room. Thank you for the hard work you're doing going into the field, helping me with this presentation and the publications we've cited, and thank you again for your attention.